Good day. Our topic for today is postpartum infection. Surgical site infections are relatively common following birth, complicating 2 to 7% of cesarean deliveries. Episiotomy sites can also become infected. Surgical site infection can be broadly divided into deep organ infections and incisional infections, which can be further divided into superficial incisional, involving the skin or subcutaneous tissues, and deep incisional, involving the muscle or fascia infections. Endometritis following surgical delivery is an example of deep organ infection. Other postpartum deep site infections include infected hematomas and pelvic abscesses. Surgical site infections and incisional site infections can present with erythema and purulent drainage at the site. Like endometritis and septic abortion, it can also cause fever and body malaise. It is most commonly caused by group A or B streptococci. Other commonly isolated pathogens include Ureaplasma urolithico, Enterococcus faecalis, and Escherichia coli. Necrotizing fasciitis of the surgical site can develop. It is characterized by rapid necrosis of the fascia and subcutaneous tissue with relative sparing of the musculature. So postpartum patients who develop necrotizing fasciitis typically have underlying medical conditions, with diabetes being the most commonly reported. So surgical site infections are likewise a clinical diagnosis suggested by history and physical examination. We can do wound culture and blood culture. If post-surgical deep organ infection is suspected, CT with intravenous contrast may help with the diagnosis. Antibiotics are the mainstay of treatment. We can give broad-spectrum antibiotics after making the diagnosis. We can give it through intravenous route with clindamycin, gentamicin, and can include ampicillin and metronidazole. For mild superficial surgical infections without systemic symptoms or purulence, an oral course of antibiotics is typically sufficient, such as cephalexin. For the breast-related complications, we have cracked nipples. The clinical features include nipple erosion and intense pain when starting to nurse. There is no fever except when associated with lymphangitis. For the management of cracked nipples, clean with soap and clean water before and after each feeding and dry carefully. Observe the neonate while nursing and correct the position if necessary. Cracked nipples are often caused by incorrect latching onto the breast. So as a review, these are the things that we have to consider for good latching. So the baby's body is facing mom's body. There is no space between their bodies. The baby's chin is pressed into the breast. The baby's nose is not touching or just barely touching the breast. And breastfeeding is not painful, it just feels like a strong tug. Next breast condition is breast engorgement. The clinical features include bilateral pain 2 to 3 days after childbirth, which is firm and painful breast. For the management, we can do cold or warm compresses before nursing. We can do gentle manual expression, especially if the neonate cannot latch onto the overly distended breast or after nursing to finish emptying the breast. Engorgement subsides in 24 to 48 hours. Next will be lymphangitis. So it is a unilateral pain 5 to 10 days after childbirth. There's local inflammation, red, and hot, painful with no fluctuation. Usually, the patient has high fever with 39 to 40 degrees Celsius with enlarged axillary lymph node. There is no pus in the milk collected on compression. The management of lymphangitis includes emptying the breast by nursing the neonate frequently on the involved side. If the mother finds nursing too painful, temporarily stop nursing on the painful side and continue breastfeeding with the other breast. And we can also give routine analgesia for pain relief. Another condition is your mastitis and abscess. For the mastitis, the clinical feature include firm, red, painful, swollen area of one breast associated with fever. There is purulent discharge from the nipple. On the other hand, breast abscess include fluctuant, tender, and palpable mass. For the management for mastitis, we temporarily stop nursing on the affected side and carefully express all milk from the affected breast manually. We can give routine analgesia such as paracetamol and do cold or warm compresses. Antibiotic therapy with activity against staphylococci may prevent progression to breast abscess such as fluoxacillin. Breast abscess needs urgent drainage as the abscess can quickly spread and antibiotics should be started to prevent progression. Thank you for listening.